I know that women deal with that a lot more than men do, but
just wait till they learn I'm a scientist as a day job. I'm a woman in STEM.
Her day job's a scientist. Her hair is blue. She's got schizoaffective disorder. She's a social media, mental health advocate, influencer person. You are blowing their minds, I'm sure.
You're listening to Inside Bipolar, a Healthline Media podcast, where we tackle bipolar disorder using real-world examples and the latest research.
Welcome to the show, everyone. This is your host, Gabe Howard, and I live with bipolar disorder. I'm also not here today. I've handed over control of the show to Dr. Nicole for this episode to do, well, whatever she likes, and I'm sure it's going to be awesome. But don't worry, I'll be back the next episode. Dr. Nicole, take it away.
Hey, everyone. Welcome to the show. I'm Dr. Nicole Washington, a board-certified psychiatrist.
And I'm Kit Wallis, and I live with schizoaffective disorder.
Kit is back with us again today. And today we are taking over. We are taking over. This is a girl power kind of day. When we brought up this episode to our producer, Lisa, she thought, we're going to talk about misogyny. And I said, absolutely not, Lisa. We are talking girl power. We are taking power back. We are not going to let the system do this to us. So that's what this episode is about, y'all. We are digging in on how people perceive us and how it affects your ability to get the mental health care that you deserve to get. So, Kit, when people look you up on social media, I would imagine there are a lot of people who just say, look, there's Kit. She lives with schizoaffective disorder, and she's just a pretty young woman. Is that how you identify?
So I actually identify as gender fluid, alternating between identifying more with being a woman, but also identifying as being agender as well. And they kind of go back and forth depending on the day, the situation, etc. But I do primarily present as a femme person. So I do identify with just being a girl. Like, I love being a girl. People do perceive me primarily as being a woman because that is how I present myself 99% of the time.
It is a shift in culture. It's a shift in how we think of patients on my end. So as a psychiatrist, when I was in training and learning how to interview patients and learning how to build rapport with people, there was no question about pronouns and gender identity. And these things were just not a thing. They were a thing in the sense that I think we can all look back now and say, oh my gosh, yes, I know lots of people who probably, if they had the words to describe it, would be able to say, oh yeah, I'm gender fluid, or I absolutely do not identify as the sex I was assigned at birth. I think there are a lot of people that we can look back on in our lives that have that thought now. It just wasn't a word. We didn't have the words for it. We didn't know how to describe it. It just wasn't a thing. So now, as a psychiatrist, at my big age, here I am, have been in practice for all these years. I have to retrain myself. To make sure that I am asking those questions when I'm interacting with people. And so for those out there listening who may find yourself in a position as a peer supporter, as a therapist, as a social worker, caseworker, doctor, because we have a lot of y'all out there listening, we have to retrain ourselves. Do you find that people struggle with how to even ask the question, or do people even ask the question?
I'll get asked what pronouns I am. And I will explain that I'm usually she, they, either is fine, but it's more complicated than that. And doesn't usually come up in a first conversation. So I just usually say she or they is fine. Sometimes I say I'm genderqueer, but I don't really dive too deep into it beyond just the pronouns for most people.
So for today's purpose, we are going to focus more on how people perceive Kit, because my thought is people look at Kit and it never occurs to them that she would say that she's gender fluid or any of those things, because I think people probably look at you and come up with their own thoughts of you and what you need and how you identify, and never even ask you a question about it.
Mm-hmm. Yeah, they do, for sure.
Yes. Okay. So one of the things that my female patients bring up often when we're interacting and having conversations, I am much more of an interactive, we're on the same team, let's come up with a plan together. What do you think? This is what I think. And a lot of them say, I've never had this before in my life. I've never had a doctor sit down and explain to me about my meds. I've never had anybody sit down and ask me what I thought. I've never had anybody really, really listen to me and take my opinion into consideration. And I hear that so much more from my female patients than I do my male ones. Has your experience been in medicine, in healthcare? You've been dealing with this for a while. Have you had that experience of people not listening to you or feeling as if they didn't value what you thought about your own self and symptoms?
For the first 10 years that I was diagnosed with a mental health condition, I did have one psychiatrist who was a man, and I definitely do want to get into that relationship a little bit more later on because he was pretty positive, and I do want to talk about that. But I will say that when I was in the psych ward, when I was in a psychiatric hospital, the psychiatrist that I interacted with there did not seem to care about me or my opinion or anything to say at all. Like I did not feel like I was being heard in really any way. I just thought I was in, out. He adjusted my meds in ways that frankly I didn't really like. And he didn't really run it by me. He just did that. And I just don't recall feeling heard at all. And he was a man. And I wondered if that potentially could have played a role in how he viewed me as a patient.
I could absolutely see how you would think that, or at least allow that thought to enter your mind. The hospital is always such a weird place because it's such a fast pace. You're in, you're out. You don't get to spend a lot of time. There really isn't a lot of rapport building that happens in the hospital for an acute episode. Both sides kind of realize we're not in this for the long haul. Like, just get me stable, get me out of here, get me home. I do think some of that's lost. I do want to know, what is it that your doctor did that was so great? Because a lot of my women patients or women presenting patients are convinced that they are not treated well because of the fact that they're a woman. I want to know, what does it look like from a patient perspective of you saying, yeah, my doctor did it right. I think he did a great job. What does a good job look like?
Oh golly. I don't have this psychiatrist anymore, and honestly I miss him very, very much. And when I was 18 and I was first going through all of these mood symptoms that were getting me a diagnosis of cyclothymia at the time, he asked me questions about like me as a person and how symptoms affected me. When I brought up something, he asked me, "Oh, what is that like for you?" It was always, "What is it like for you? How does that affect you?" And it was like he was asking questions to know a little bit more than what I was expecting him to want to know about. And over the time that I had him as my psychiatrist and my diagnoses got more and more upgraded, so to speak, he never quit asking me questions about what things were like for me. Like I remember when I was telling him that I was experiencing proprioceptive hallucinations, which are a kind of hallucination that deals with your body knowing where its parts are. So I'll feel like I slipped on a banana when I'm standing still, or I'll drop a few inches while I'm walking, etc. And I remember telling him about that and him just asking so many questions about what that was like for me and how it affected me and what it did and how it affected my life. And I always thought it was interesting that there was a level of curiosity that he had that I just haven't had with people since then. But he never lost that in the 10 years that he was my psychiatrist. And I would say that was probably the number one thing that made me feel like I was being heard and respected. Because I'll admit, when I first heard that my psychiatrist was a man, and I'm like 18, I'm young, I did not have high hopes, if I'm being honest. I really would have rather preferred to have a woman, because as someone who identifies primarily as a woman, having a woman psychiatrist, I felt like would be more comfortable for me. But I was pleasantly surprised when it came to him and how he was a doctor for me.
Yeah, it sounds like he treated you like a person, which
He did,
shouldn't
yes.
be.
Yeah, he did.
He just treated you like a person, which it sounds like he treated you like a human. And I don't know where we went wrong. That's the bar is, oh my gosh, he was the most amazing person because he treated me like everyone should be treated. You know what I mean? Like, I mean, doesn't that seem a little odd that we do in these settings tend to celebrate people who are doing, when you think about it, what we should all be doing?
We shouldn't be clapping for basic human decency. Like, I don't
Yeah.
I don't feel like that should be a thing, but yet I find myself doing it all the time anyway.
Yeah. And I like that you even brought up that you brought your own stuff into it, because I think we do bring our own. I know that we bring our own things into these interactions. We bring all of our previous experiences with men who are older than us into these situations. I can remember being a young woman doctor, young woman student, and I learned early about transference and countertransference, and I learned a lot within my own self. I learned that we bring these things into all these interactions, and patients absolutely bring in with them their own thoughts about working with that particular gender of doctor, that particular age. I have had to work through a lot with patients. I've had patients who have had very strained relationships with, let's say, the women in their lives. And now that I'm a middle-aged woman who have issues with their mom, and they're bringing all that into our sessions, all of that is carried with them into that.
You mentioned transference and countertransference. Can you dive a little bit deeper into that?
That's a really fantastic question. Sometimes I use these words so much, we forget that these aren't words that everybody uses in their day to day life. So, transference is a phenomenon by which a patient is going to walk into a relationship with their therapist, their psychiatrist, anyone in that capacity, and they are going to have feelings about them. They're going to have thoughts about them that really aren't based on that interaction. They're based on the patient's past feelings, past experiences with someone who maybe reminds them of it. So here I am, a middle-aged woman. If I have a young patient in with me who has a relationship that is somewhat difficult with their mother, who happens to be around the same age as me, sometimes they can bring transference into that relationship. Sometimes it creates problems in that relationship. Countertransference is me, the person given the care. It's me putting my stuff onto other people. One of the things I learned early on in my career as a new doctor, a new psychiatrist, a psychiatrist in training, I quickly learned what populations of people I had strong countertransference to. And sometimes that countertransference was negative, and sometimes it was positive, but maybe so positive that it interfered with me treating that person the way that I would treat everyone else. And that's really where the problem comes in, because if you walk into the situation as the patient, and if those past experiences and feelings are going to interfere with our therapeutic relationship, that's going to be a problem. If me as the doctor, if I walk into that relationship and my past feelings and experiences are going to interfere with me being able to give you that objective care that I'm supposed to give, that's a problem. So it only makes sense that you can see that play out, that transference play out. Like you said, young woman, I'm going to a man. I have low expectations. I'm not sure what to think, because whether it's our own personal experiences or whether it's culture and pop culture and what we see on TV and what we think about certain groups of people, it's going to interfere, or at least has the ability to interfere.
Growing up, I was catcalled by older men a lot. I was hit on by older men a lot. And so knowing my psychiatrist was going to be an older man was I had to get past some stuff. And I gave him a chance, and I'm glad I did. But I did go into it with like all these feelings and all these experiences of getting this stuff from older men that really shouldn't be doing that to young girls. But
Yes.
it still happened, and I still had to deal with it. So thank you for explaining that.
Yes. And so you can absolutely, as a woman, bring into your healthcare experience all of your previous feelings and emotions about someone else, and you can bring that in there and not even be aware of it. That's one of those other reasons that I always think therapy is so valuable in this space, even though people think, oh, bipolar disorder, not really for therapy. Absolutely, because all those things are important. But it is also important to note in your scenario that he did listen to you. He didn't just tell you what he thought you needed to do and send you on your way. He didn't just say, oh, Kit, she doesn't know. She's young, she's pretty, and she can't possibly know what she needs for herself. So I'm just going to tell her. because she can't possibly know. I mean, I think a lot of my women patients walk out of encounters feeling like that. Like people have just thought, "Oh, you can't possibly know what you want."
Oh, I felt great every time I left my appointments with him because not only would I feel listened to and heard and feel positive about how my treatment was going, but we also kind of got into this pattern where he would answer my questions about mental health, anything related to psychology, psychiatry. Like I would come in with a question about something, say I was researching in my spare time, and I would ask it to him, and he would tell me what perspective he had on it because I knew he read papers all the time. So we would always have this brief, short, scientific based conversation. And as someone who is an intellectual, I really appreciated that. And so I always felt good leaving his appointments for multiple reasons.
Yeah, I love that you had that experience, and I'm sure that has shaped your ability to open up and to continue in treatment as long as you have. One of the spaces where my women patients tell me they feel that misogyny or they feel that discrimination the most is in family planning, in the discussions about what medications you will take, what medications you can or cannot take. Again, I trained a long time ago. When I trained, we did have the thought that, oh, there are certain medications we just would never give a woman of childbearing age because they might get pregnant on the medication and they are at risk for having birth defects in the baby. So we just won't even offer that as an option. I think the culture has shifted a little bit to where we're at least having these conversations and open to having these conversations. But before, it just wasn't even a question. You just said, "Oh, you're a woman. Oh, you could possibly get pregnant," regardless of whether you have sex at all, regardless of whether you have sex with men or women, regardless of any of those things. We just decided that because you could possibly get pregnant, we just weren't going to give you something. Have you experienced anything like that in your treatment?
In my mental health treatment, no, fortunately. I've been very lucky, and I think I am a product of luck in a lot of ways when it comes to this kind of thing. And I know I'm very fortunate in that sense. And I know some of the medications I take do run the risk of causing birth defects if I was to have a child. But fortunately for me, my treatment providers are actually pretty understanding of my situation and the fact that I don't want to have kids. So they've never not prescribed me something based off the fact that I am a woman of childbearing age. And I do not take that for granted for sure, because there are a lot of women out there that get a lot of crap when it comes to these kinds of things.
Mhm. I have a lot of women patients who tell me, Dr. Nicole, I have bipolar disorder or I have schizophrenia, or not even I have such a strong family history of these things. I have decided after a lot of thought that I don't want to have kids. I don't want to. That only becomes a problem when these women try to take the next step to prevent that. And they say, beyond birth control, beyond those measures, I want to have my tubes tied. I want to have them removed. I want the tubal. I don't even want the possibility of becoming pregnant. And I say we, as a medical community, really struggle with the reality of that person sitting in your face knowing that it's a very permanent decision. So we've talked before in our getting to know you, preparing for these episodes, about how you made that decision that you were not going to have children and that you felt pretty supported in that decision and you were able to figure out how to navigate that. But not everybody is able to navigate that, it seems, as easily as you were. Can you tell us a little bit about your experience with that?
My road to getting a bilateral salpingectomy, which is basically the term for getting all of your fallopian tubes removed — I did not get them tied, I got them removed — was easier than I had anticipated. And it was easier in the sense that I thought I was going to have to bring a binder with all the reasons that I wasn't going to have kids. I thought I would have to seek out a doctor that was known to provide the surgery to young women like myself. I'm 29 as of recording this, but I was 27 at the time that I got my surgery. And I thought it was going to be really difficult. And I was pleasantly surprised to go to my gynecologist and say, hey, I would like to get my tubes tied. I really don't want kids. what are my next steps? And she sent me to a surgeon, and I sat down with the surgeon, and I was all ready to like get my reasons. I was already like, I knew my reasons. My reasons in short were I have a severe mental illness. It can be passed on to kids. That wouldn't be good for the child. In addition, me and how my disorder affects me, I'm not sure I'd make a good mother. And by I'm not sure, I mean I would not make a good mother. Not to beat around the bush at all. It would not be good. And so those are my main reasons for it. And so going into the appointment, I was ready to slam the numbers down and be like, this is, these are the statistics for the chances of this happening and all this other stuff. And she actually said, okay, here's the brochure. I recommend you just get the fallopian tubes removed entirely. And when do you want to get it done? And I was shocked because I didn't expect it to be that easy. And I actually asked her, I said, you're not going to ask me why or anything? Like, not at all? And she said, well, you're here. You very clearly have made the decision, and I trust you've made the decision with what you want to do, and it's very clear you want to do this. So yeah, when do you want to get it done? And I was so happy because I thought I was going to have to be rejected. I thought I might have had to get a permission slip essentially from my father because I didn't have any man in my life. Never mind, I'm not into men only, but it's yeah, just to be frank. But in the medical field, when it came to actually getting it done, I did not have any pushback. Actually, I was pleasantly surprised.
Wow, that is actually surprising because the stories I hear are people saying, "Oh my gosh, they ask me a million questions." And the big question that people usually get asked is, "But what if you meet the right person? And what if you decide down the road that you do want to start a family?" And those are the questions that women get asked that sometimes frankly drive them up a wall, and they're so frustrated.
And we're back discussing gender dynamics in mental health care.
Now, I do think it's important to remind ourselves that it is permanent and that there is also the risk that down the road, a person could change their mind. And I know for a fact that I have seen lots of people who have not necessarily had them removed, who have had the procedure where they go in and we say it's tying your tubes, but it's not really tying your tubes. But I see people who've had that procedure done who are now thinking, oh, I think I want to try to get it reversed. And there's the frustration of, oh, I wish I hadn't done it. I mean, that does happen. It does. I don't think we can totally ignore the fact that those people exist in the world. There are people who are jumping up and down decades later, like, whew, thank goodness. Thank goodness I was allowed to get this done.
That's going to be me. That's going to be me.
That's going to be you. Like, whoa.
Yeah.
But there are also people out there who get these procedures done and they do regret it. And that's tough. And I think it's even tougher for the doctors who actually do the surgeries because there have been some cases where you hear about doctors who have been taken to court because the person comes back and says, I don't know that I really understood that this was permanent. I don't know that I really understood the gravity of the decision I was making. Now, the consent forms are very clear that this is permanent. There's no question about whether it's permanent, but these are the things that we hear about. These are the cases, even though they may be rare, these are the stories that are haunting the nightmares of gynecologists when a young woman who doesn't have kids or who maybe only has one kid or who has kids but is single or who has kids but is young or who's single and hasn't met Mr. Right yet. These are the things that haunt them in their sleep. Those stories of the person who comes back and says, but I hadn't even met my husband yet and now I met him. Those are the things that they worry about.
There was a funny moment I had actually right before I was being put under for my surgery where I was talking to the doctor. I'm like, I read that there's a 30% regret rate. This is kind of like the most permanent thing I've probably ever done. And then he looked at me and I'm like on the meds they're giving me before being wheeled back. And he said, you have a tattoo and you did that first. And I was like, what? So yeah, he's like, he was talking about more permanent things. He's like, you've already got a tattoo on your body. You've done a more permanent thing.
I don't know. You can get tattoos removed.
I know. I was like, but it was just so funny to me. And I'm like, I mean, if I'm remembering that properly, I was like a little bit woozy, but I just thought it was so funny that he brought up the fact that I had a tattoo, and I'm telling him, I'm like, this is a pretty serious thing. This is probably the most permanent thing I've ever done. And he's like, we already have a tattoo. I'm like, what?
You already have a tattoo. Go to sleep. We've given you drugs. Go to sleep. The other side of this coin that you're talking about, though, is the person who says, I want to have kids. Yes, I live with bipolar disorder, but I want to have children. I still want to have a family. I still want to move forward. And I heard you say very clearly, for you, it was not okay. You wholeheartedly believe that Kit as a mother was not a good idea. And I want to make sure that for the women who are listening who say, well, but I mean, that was her. I want to have kids. Then absolutely, you with your bipolar disorder should still be able to make that decision as well. And I do think we sometimes on the other side see women getting talked out of having families because they have a mental health disorder. And that's also not okay.
So one thing I always try to tell people when this type of thing comes up in conversation, because I'm very open about not wanting kids because of my mental illness, is that there's another side of the coin. And that is, say someone has bipolar disorder and they have a child, and the child goes on to develop bipolar disorder. There's probably no one better equipped to help that child deal with bipolar disorder than the parent who has it and is managing it. And I think that's really important to remember, because these situations, they can work. They can be successful. And there's also the chance that the child might not develop bipolar disorder at all, and they could just be who they are without having to worry about mental illness. There's also that possibility. So it's not a guaranteed thing that someone with bipolar disorder, their child will go on to develop it either. I just don't want to take the risk for myself, because I know myself and my situation. And I never, ever want people to think that because they have a mental illness, they should not have kids. They should not risk having children. Like, that is definitely not the message I ever want anyone to get from anything I ever say.
Yeah, it is absolutely a very individual decision.
Mm-hmm.
And whatever the decision is that you make, it's your decision to make, regardless.
Absolutely. Absolutely.
So beyond healthcare, because I talk to a lot of women. A lot of women come to see me because I'm a woman and they feel comfortable talking to me and they don't feel dismissed. And so I get a lot of the tea. I get a lot of the stories of the things that are going on in my patients' lives. And I have learned that socially, there's also this phenomenon of being a woman with bipolar illness or a woman with schizoaffective disorder, and how people sometimes even treat you different socially as a woman with a mental illness.
Oh, absolutely. Absolutely. Whether it's online and in real life, I definitely get a lot of crap for being a woman who's mentally ill.
When it comes to dating, when it comes to getting to know people on that level, I have heard from women, especially when they date men, that they find that men are almost infatuated with this whole wild, not quite stable woman, passionate, whatever you want to call her, that's linked to them having a mental illness.
Oh, definitely. Men are into quote unquote crazy girls. And as someone who has a mental illness, people tend to group me in that category, and they almost romanticize it in a creepy way. As a woman with a mental illness, I fall into that category for them, and it puts me in some pretty uncomfortable situations at times. And I would say the most of that comes across in my online life, where people can say those wild things and get away with it. I don't really get it as much in real life, but it has still happened in real life for sure. And it's very off-putting, to put it plainly. But I do know that there's also a subset of people that aren't interested in that at all. Like, I used to be on Tinder, and when I started advertising that I had schizoaffective disorder, I quit matching with people on Tinder, which was very interesting and a little bit sad. So I haven't been on Tinder since then. But in recent years on my social platforms, I do get a lot of men that romanticize my mental illness and say, oh, you're the crazy girl that I want to be with. Oh, if I could just get a crazy girl like you. And I just ignore, I block and whatnot. But it's not fun because it's very stigma oriented. And I really don't like the romanticization of like mental illness in that way. And I'm like, I'm stable, I'm balanced, I'm not what you like. This is not, it's also not healthy. Like there are people out there that truly believe that if they end up on Dateline after dating a girl, that's what they want in their life. Like they want that to be their reality. And I'm just like, that's not good. And so it's encouraging unhealthy relationships in addition to just being incredibly rooted in stigma.
Yeah, and it's a little wild to me because these people don't really know you. They've never been around you. So they don't have a frame of reference of, oh, this is what Kit is like when she's not stable, or they're literally just going off of the fact that you're an advocate, you're open about your diagnosis, and they just think they want that. They have no knowledge of what it actually means to be in relationship with someone who has a severe mental health disorder. I mean, they have no clue what that's even like.
They have no clue that I take medication every single day to treat it, which keeps the symptoms down. I'm in therapy quite often to deal with the emotional aspect and whatnot. I have lifestyle changes that I keep up with. I'm a pretty like stable person, and it's not, I'm not emotionally volatile. And assuming that I am because I have a diagnosis just makes me so mad. It pisses me off, frankly.
Yeah.
Because getting grouped into that category of people who do act that way in some cases, because there are some people that do act that way, but saying that we're all like that because of a few just is so rooted in stigma, and I hate it.
What I hear you saying is they have no idea how boring you actually are.
Oh my God.
They have no idea how...
I'm in bed by 8. I wake up in the morning. I have my coffee. I go to my 9 to 5.
Right. I mean, I tell my patients probably once a day, I tell a patient excitement is overrated. Like excitement is so overrated. You know what's sexy? Stability is sexy.
Yes.
Being in bed by 9, taking your meds every day, being able to get up and go to work, being able to go pay way too much for groceries like everybody else. That
Buy
is sexy.
Eggs.
Right. Like that's sexy. Being able to go pay that much money for eggs, that's what's sexy.
Adulting.
Yes. Adulting is sexy.
I'm so grateful that I get to adult all the time thanks to my treatment.
Yes. And that you're not. And I do think that what people perceive as this crazy woman trope, most of the time, those people don't have a disorder like a bipolar disorder or a schizoaffective disorder. Like that's not what this is. So it just goes to show you just how uneducated a lot of these people are. And not even just uneducated, it's the audacity. It is as a woman, the audacity that you have to deal with, because nobody hardly ever is going up to men and saying these things. Nobody's going up to men like, I really like a crazy man. Somebody may be, but...
Oh, it definitely happens.
I'm sure it happens. But I can guarantee you it is not happening as often. Nobody's telling men, nobody's telling men, oh, you shouldn't take this med because we don't want it to interfere with your ability to have kids. Or, oh, you look like somebody I want to date because you look really unstable. Nobody hardly is saying that like they say it to women.
Well, I also get a lot of crap for having blue hair. So I have blue streaks in my hair, and there is a stigma associated with women who have blue hair, and it's that they are quote unquote crazy again. So I get a lot of crap online for having blue hair. People say, oh, the blue hair checks out on my videos, and just like, come on, people, like I can't catch a break. And I didn't know that before I dyed my hair blue, by the way. So it was a total shocker to me. But having blue hair on the internet while also having a mental disorder just ups the "you're crazy and I'm into you" comments for sure.
Yeah, my hair was blue for about a year and a half, and
Oh, did you get anything for it?
well, I would get the opposite. So I'm not a social person. Anyone who knows me knows I'm not warm. I'm not fuzzy. I'm not a small talk to me strangers in public. And people just started talking to me out of nowhere because it's like they thought, oh, your hair is blue. You look approachable, or oh, your hair is blue. I need to figure out what her story is because her hair is blue. And in talking to me, they would ask questions. And y'all, I don't even tell people I'm a doctor half the time when I'm out in public and people ask me what I do. I don't want to talk to strangers just that much. So I don't even say, because when I say I'm a psychiatrist, the first thing people say is, oh, she's going to analyze me. Oh, maybe I really need you here because I'm crazy. People just say stuff like that and I get sick of it. So a lot of times I lie. But in the times that I would say that I was a doctor, I would get some pretty strange looks like, huh, like, oh. And I do think it's because they just assumed I had to be doing something else. Like, there's no way I could be smart and have blue hair. Like, you have to not have a career to have blue hair. I think people do make a lot of assumptions about us based on our appearance. But I also think we do that about a lot of people. You know, I have male colleagues who have lots of tattoos or who have an appearance that doesn't kind of line up with what you think a doctor should look like. And whenever we buck the system or we go outside of what people think we should look like, we get into a lot of assumptions about us. And I really hate that. And I know that women deal with that a lot more than men do, but they do deal with it as well.
Just wait till they learn I'm a scientist as a day job.
Her day job's a science. Her day job's a scientist. Her hair is blue. She's got schizoaffective disorder. She's a social media, mental health advocate, influencer person. You are blowing their minds, I'm sure.
I have a lot of fun. One thing that I actually have a question about, Dr. Nicole, is in my experience as someone on the outside who sees society, not as someone who is literally in the medical field, I've noticed that people tend to think that women are naturally more emotional, and because of that, they're naturally more volatile and thus more mentally ill. So, in your experience being a psychiatrist, have you seen that kind of thing in your patients?
I have. You know, Kit, people like to assume that women are just more emotional. They're more labile, so more up and down emotionally. And it's really frustrating to me because I genuinely believe that men are just as emotional, if not more so, than women are. But for whatever reason, we just like to do this thing when it comes to women and their emotions. But I think that's largely because men don't do it in the same way. Men will go and have an anger outburst or be very upset about something, or it comes out as this intense anger. And we're somehow okay with that because it's okay as long as he's not crying and slaying snot and falling out and being all dramatic. We're okay. We're totally okay with men being angry and violent and volatile in that way. We're not okay with men crying and being soft. We're okay with women being super emotional and we roll our eyes and we just say, oh, she's just being dramatic or she's hysterical, right?
No, yeah.
We don't say that. When women are angry, they're the B word. When men are angry, it's okay because he's just getting his emotions out and that's just what men do. And we don't just do it with people who are mentally ill. We do it in the workplace. If I go into the office and I am short with staff because there was a mistake that was made, I'm called the B word. I'm an angry Black woman. She's difficult to work with. I'm intense. Those are the words that get used. I make people uncomfortable. I have worked with men who have thrown charts in the office. I have worked with male doctors who have literally thrown charts across the room and nobody's calling them into HR. Nobody's saying, oh, he's so intense. No, he's passionate. He just expects a lot from those who work for him. He is not viewed the same way as I am. And that is across the board. When you think about diagnoses, and we talked about previous episode, how schizoaffective disorder is diagnosed more in women. And we talked about why is that? One of the theories is because depression is diagnosed more in women, and there is a depressed type of schizoaffective disorder. We've talked about that. With bipolar disorder, we don't see that gender difference, and I think that's because mania is kind of a great equalizer. When you're manic, all bets are off. We're going to see it. We're going to see it regardless of how it presents. We're going to see it and we're going to know what it is. So we're seeing more of that. I think we miss a lot of men who probably have depression, but we don't see it because it's more socially acceptable for a woman to say, I'm down. I need help. I'm going to go talk to somebody. I'm going to go see somebody. We're okay with that. Men don't always feel that they have the room to do that or to say, hey, I'm in a vulnerable spot. I'm down. I need help.
I actually get that with men in my life because being someone who is an open mental health advocate, I talk about mental illness a lot and I talk about it to my friends, my family and whatnot. But there's a significant portion of the people in my life that even though I talk openly about mental illness, they are so quiet about anything remotely close to anything mental illness related to them. And those people are disproportionately male. And I'm not going to call any of them out. Not call any of them out at all. But I've got people in my life that like they really stuff it down because they're just so afraid of what society would think of them if they were to have any kind of problem. And that's something that really needs to change, in my opinion. I think we'd be better off as a society if men felt comfortable enough to talk about their problem, talk about their issues. Maybe we'd have less of those anger outbursts if they could actually talk about their feelings to somebody.
Yes. Imagine that. Imagine a world where men just said, I'm not okay, instead of throwing something across the room.
Yeah,
just
throwing
imagine.
a chart. Throwing a chart. If you threw a chart, you would probably not have a job. Like,
oh, I absolutely wouldn't have a job if I threw a chart. Absolutely not. Kit, thank you so much for being here. Where can folks find you online if they want to follow you?
The number one place you can find me is on YouTube. I am Schizo. That's schizo like schizophrenia, and Kitzo, Kitzo. I'm also on other social media platforms like Instagram and Facebook, but YouTube is where you will find all of my best content.
Thank you again for being here. And to all of our listeners, thank you for being here as well. I'm Dr. Nicole Washington. You can find me on all social media platforms at Dr. Nicole Psych or on my website, drnicolepsych.com. Wherever you downloaded this episode, please follow or subscribe to the show. It costs you nothing. And do us a favor, share the show, send a text message, put it on social media, bring it up in a support group. Send an email, get one of those fun car wrap things and wrap it on your car. No, don't do that. Please don't do that. But sharing the show is how we grow. We'll see everyone next time on Inside Bipolar.
You've been listening to Inside Bipolar from Healthline Media and PsychCentral.com. Have feedback for the show? Email us at show@psychcentral.com. Previous episodes can be found at psychcentral.com/IBP or on your favorite podcast player. Thank you for listening.